All right, when it comes to treating heart failure, we've got this incredible showdown happening. On one side, you have a drug that comes from a flower, something we've been using for over 2 centuries. And on the other, these tiny, super smart computers we actually implant right into a person's chest. So let's get into it. So that really is the big question, right? Where do you put your money? Is it on the old school pharmacology of Digoxin or the high-tech precision of modern devices? And this isn't just, old versus new. We're talking about two totally different philosophies for how to help a heart that's struggling. Okay, so let's kick things off with the old classic Digoxin. For generations, this was a go-to drug for heart failure, but wow, has its role changed over the years. It's not really a first-line player anymore. Think of it more like a specialist, the one you bring off the bench for a very specific job. So when do we actually call on this specialist? Well, it really boils down to two main situations. First, you've got a patient who's already on all the best modern meds, but they're still having symptoms. You add Digoxin on top to give them a bit of extra relief. And the second big one is for folks who are dealing with both heart failure and that chaotic heart rhythm we call atrial fibrillation. Digoxin's great there for helping to get the heart rate under control. Okay, this slide right here, this is probably the single most important thing you need to know about Digoxin today. Let's be super clear on this. Digoxin can absolutely make patients feel better. It can even keep them out of the hospital, and that's huge. But, and this is the big but, it doesn't make them live any longer. Think of it this way. It helps manage the journey, but it doesn't actually make the road any longer. And this, of course, brings us to the flip side of Digoxin. You see, the line between a helpful dose and a dangerous toxic one is incredibly thin. It's like walking a tightrope. This is a drug you really have to respect and keep a close eye on, because if you cross that line, things can get serious fast. And you know what's tricky? The first warning sign usually isn't some big, dramatic heart issue. It's a lot more subtle. It usually starts with the stomach. A patient suddenly loses their appetite, feels nauseous, maybe starts vomiting. That's often the very first clue that the digoxin level is too high. Now, if we hook someone up to an EKG to see the heart's electrical activity, the first thing we'll probably notice is something called PR prolongation. And all that means is that the little electrical signal is taking just a fraction of a second too long to get from the top of the heart to the bottom. It's like a tiny traffic jam in the heart's wiring. But if things get worse, that's when you can start seeing some really weird heart rhythms. The classic one, the one that screams digoxin toxicity, is called ventricular Bigeminy. It's this weird normal beat, weird beat, normal beat, weird beat pattern. It's a dead giveaway. All right, this is super important. Sometimes knowing what isn't there is just as helpful as knowing what is. This is like a cheat sheet for doctors. If you see a patient on digoxin and they have sinus tachycardia, a fast, regular heartbeat, or this specific block called a Mobitz type 2, you can pretty much rule out digoxin as the cause. It just doesn't do those things, so you've got to look for something else that's going on. Okay, so what do you do if you confirm its toxicity? There's a clear game plan, and it happens in these 4 steps. Step 1, and this is a no-brainer, stop the drug immediately. Second, you've got to check their potassium. Low potassium makes this whole situation way worse, so you get that level corrected. Third, if there are any dangerous arrhythmias popping up, you treat those with specific meds like lidocaine or phenytoin. And finally, if it's a really bad case, you bring out the big guns, the antidote. It's called Digibind, and it's made of these antibodies that literally go in and soak up all the extra digoxin like a sponge. It's pretty amazing stuff. So with all these risks we've been talking about, it makes sense that there are some situations where you just can't use digoxin, period. These aren't just suggestions, they're hard and fast rules, red lines you do not cross for patient safety. And this list here shows you exactly what those danger zones are. For example, in someone with Wolff-Parkinson-White syndrome, giving digoxin can actually make a bad rhythm dangerously fast. Or if someone already has a serious electrical block in their heart, digoxin could just shut the whole system down. It's like throwing gasoline on a fire in these cases. You just don't do it. Okay, so that's the old guard. Now let's switch gears and talk about the new tech. Because when a drug has too many risks or just isn't powerful enough, we stop looking in the pharmacy and start looking in the engineering lab. And this is where implantable devices have completely changed the game for heart failure. The two big players on the device team are the ICD and the CRT. And the easiest way to tell them apart is with an analogy. Think of the ICD as a personal bodyguard. It just sits there watching 24/7 for a deadly rhythm, and if it sees one, bam, it delivers a shock and saves your life. The CRT is different. It's more like an orchestra conductor. Its job is to get a heart that's beating all out of sync to work together in perfect harmony. It coordinates the beat to make the pump stronger. So let's talk a little more about that Bodyguard, the ICD. It's basically a life-saving safety net. And the main reason someone gets one is when their heart's pumping power, we measure this as the ejection fraction, or EF, drops below 35%. Once you get below that number, the risk of just suddenly dying from a chaotic heart rhythm goes way, way up. So the ICD is there, standing guard, ready to stop that from happening. So what about the orchestra conductor, the CRT? Who gets one of these? Well, the rules for this are really specific. First off, just like the ICD, your heart has to be weak, with that ejection fraction under 35%. Second, your underlying heart rhythm has to be normal sinus rhythm. And third, and this is key, your EKG has to show a very specific pattern called a left bundle branch block. This basically proves that the two bottom chambers of your heart are beating out of sync. So the CRT comes in, paces both sides at the same time, and forces them back into a nice, strong, coordinated rhythm. And here's the really cool part. A lot of the time, you don't even have to choose between the two. Engineers figured out that a lot of the patients who need the orchestra conductor also need the Bodyguard. So what did they do? They put them together. It's called a CRTD, and it's one device that does both jobs. It makes the heart pump more efficiently every single day, and it's also there to deliver that life-saving shock if it's ever needed. It's really the best of both worlds. And that brings us right back to where we started. We've looked at this ancient drug that's good for symptoms, but has some pretty serious risks. And then we've seen these modern devices that can actually make the heart stronger and literally stop you from dying. So it leaves you wondering, doesn't it? As we look to the future of treating heart failure, is the next big revolution going to come from a pharmacy, or is it going to come from an engineering lab?